Bienvenidos, es una alegría para mí invitarlos al Simposio Takeda, que comparto hoy con mi compañera la doctora Astrid Pavlovsky. Vamos a hablar sobre qué hay más allá del ABVD en el tratamiento de primera línea del linfoma de Hodgkin. Contamos con la presencia virtual para el momento de preguntas y respuestas, luego de su cápsula, con el doctor Martin Hutchings. La modalidad del simposio va a ser dos presentaciones. Astrid en breve va a hacer una situación en dónde estamos, dónde estuvimos respecto del linfoma de Hodgkin, para luego dar lugar a la charla del doctor. Las preguntas, por favor, las pueden hacer en el micrófono. Va a haber traducción simultánea para el momento de la charla, pero las preguntas van a ser en inglés. No hay inconveniente si tienen dificultad o no se atemoricen. Es lo más importante poder disfrutar de él y de sus respuestas. Nosotros podemos traducirlas si fuera necesario. Así que, bueno, sin más, voy a introducir al doctor Hutchings. La mayoría lo conocen, es consultor hematólogo del Departamento de Hematología del Hospital Universitario de Copenhague. Tiene una amplia trayectoria en investigación básica y clínica en Hodgkin. Ha hecho su tesis doctoral en PET-TC y el rol metabólico de estas imágenes. Ha sido presidió el grupo de linfoma de HORTC desde 2013 al 2017 y sobre todo es el responsable de la dirección de la unidad investigacional de estudios de fase 1 a fase 3 traslacionales en el campo de las neoplasias linfoproliferativas. Y las presento a la doctora Astrid Pavlovsky, que todos la conocen. Astrid es directora médica del Instituto Pavlovsky, es médica hematóloga en FUNDALEU, comprometida con el estudio de las patologías linfoides, participa en el GATLA activamente y bueno, participa además activamente en numerosas sociedades científicas y bueno, todos la conocemos y estamos encantados de escucharla. Muchas gracias.
Bueno, gracias Caro y gracias a todos por estar acá para conocer un poco más de qué hemos logrado y dónde estamos en pacientes con linfoma de Hodgkin clásico. Estos son mis conflictos de interés. Y esto es un registro recientemente publicado de casi 5.000 pacientes en Dinamarca tratados por diagnóstico de linfoma de Hodgkin, que nos habla de algo que ya sabemos y conocemos, pero que nos vuelve a reiterar la importancia. Nos está yendo muy bien en el tratamiento de primera línea y en estas líneas B, vemos como a lo largo de las décadas la mortalidad relacionada al linfoma de Hodgkin cada vez va disminuyendo y hoy estamos en la línea azul. Y lo que también vemos, incluso al momento actual, es que sigue estando presente la mortalidad relacionada a otras causas. Si bien estamos muy bien, podemos ver que las curvas se pueden aún ir mejorando y en eso es lo que estamos haciendo. Y un poco nos planteamos cuál es el mejor tratamiento para pacientes con linfoma de Hodgkin en primera línea. Esto se basa en dos factores muy importantes. Primero, que sabemos que la mayoría de los pacientes se van a curar, o sea, la enfermedad de Hodgkin es una enfermedad altamente quimiosensible y sabemos que la mayoría de la gente se va a curar de esta enfermedad. Y también sabemos que son pacientes muy jóvenes, con una mediana de presentación de 33 años al diagnóstico. Con lo cual, ¿cuál es el éxito de este tratamiento de primera línea? Es lograr una supervivencia a largo plazo de este grupo joven de pacientes. Y eso depende de dos factores absolutamente interrelacionados, que es claramente un tratamiento exitoso al diagnóstico para erradicar el linfoma, pero evitar la toxicidad aguda y sobre todo aquella a largo plazo que puede generar mortalidad en este grupo de pacientes que van a estar en remisión completa décadas después. Y eso es principalmente segundas neoplasias y enfermedades cardiovasculares. ¿Cómo ha avanzado esto? Bueno, ya hace casi 50 años que se escribió y se publicó por primera vez el ABVD y sigue siendo al día de hoy un tratamiento de primera línea y de elección en muchos países del mundo para pacientes con estadios avanzados debido al buen balance entre la eficacia y la toxicidad. Unos años más tarde, en el año 2003, el grupo alemán publica unos resultados con BICOP, un tratamiento más intensivo que logra un mejor control inicial de la enfermedad en estadios avanzados, pero que se relaciona a mayor toxicidad relacionada al tratamiento y sin evidencia clara de mejorar la sobrevida global. Con lo cual, algunos grupos están decidiendo iniciar tratamiento con BICOP, pero el ABVD sigue siendo vigente al día de hoy. Con lo cual este es un debate muy viejo que durante mucho tiempo escuchábamos si ABVD versus BICOP o BICOP escalado en pacientes con linfoma de Hodgkin en estadios avanzados. Eso quedó un poco viejo y se introdujo en el 2005 el PET-TC para evaluación de la respuesta. ¿Y por qué cambió tanto esto? Porque se observó que el resultado del PET interino es el factor pronóstico de sobrevida libre de progresión y sobrevida global más importante tanto en análisis univariados como multivariados. Entonces empezamos a tratar a nuestros pacientes con un tratamiento adaptado al PET. Y este es el debate viejo, no es muy viejo, pero creo que ya es un poco viejo, que es si debemos o no hacer tratamientos adaptados al PET-TC. ¿Qué es lo que queremos lograr con esta metodología? Es tratar de tener un balance justo y aprovechar esta oportunidad de ver lo importante que es el PET interino en tratar de reducir la intensidad del tratamiento en aquellos pacientes que responden rápidamente al tratamiento con quimioterapia, logrando una remisión completa después de 2 o 3 ciclos de quimio, con un PET negativo, donde sabemos que el fallo al tratamiento de quimioterapia es muy bajo y esto se da en casi el 80% de los pacientes con estadios avanzados. E intensificar el tratamiento solamente en ese 20% que no logró un PET interino negativo. Estos son los 3 estudios randomizados controlados más importantes que han desescalado el tratamiento en aquellos pacientes PET negativos. El RATEL, después de 2 ciclos de ABVD, descala el tratamiento y randomiza entre ABD, sacando el ableo, o ABVD. El AHL 2011, después de BICOP, en PET negativos, randomiza entre continuar con BICOP o descalar a ABVD. Y los alemanes finalmente se animaron a usar también el tratamiento adaptado al PET y en PET negativos descalan a 4 versus solamente 2 ciclos más de BICOP. Y como pueden ver, todos los protocolos mostraron que luego de un PET negativo, descalar es seguro y eficaz sin diferencia en las ramas randomizadas. Y esto tampoco, si vemos los 3 estudios con diferentes estrategias, empezando con ABVD o BICOP, no mostraron diferencias en sobrevida global y donde la mayoría de los pacientes sobrevive. Fíjense que la sobrevida global es de alrededor del 96%, donde muchos pacientes no mueren por linfoma de Hodgkin. También el PET nos ha enseñado a ver si podemos no irradiar a pacientes con masa bulky, estadios avanzados. Este es un estudio específicamente dedicado a eso, donde luego de un PET negativo en pacientes con masas de 5 centímetros o más, se randomizó entre radioterapia y no, y los resultados fueron exactamente iguales en sobrevida global y sobrevida libre de progresión. ¿Y qué pasa con los PET positivos? ¿Qué pasa si escalamos? Parecería ser que si después de ABVD escalamos a BICOP, parecería ser que los resultados son un poco mejor, alrededor del 67%, que si seguimos con ABVD, pero esto no está claramente demostrado. Y así pasamos entonces ahora a tratar de incorporar en primera línea aquellas drogas que han demostrado ser tan eficaces y seguras en pacientes con linfoma de Hodgkin recaído y refractario. Y es por eso que hoy estamos presentes a este nuevo debate, si debemos o no incorporar el brentuximab en primera línea. Y para eso le damos la bienvenida al doctor Hutchings, ya presentado y con amplia experiencia en este tema. Muchísimas gracias.
Hello, good morning. My name is Martin Hutchings. I'm a senior consultant at the Department of Hematology in the Phase 1 unit at Rigshospitalet in Copenhagen, Denmark. I'm very grateful for the opportunity to attend this symposium. Thank you very much for the invitation, and happy to address you on the recent developments in first-line treatment of advanced stage Hodgkin lymphoma. I will include the recent update from the ECHELON 1 study after a median follow-up of 6 years. These are my disclosures, and of course, support from Takeda is relevant for the content of this talk. So first, a little background on advanced stage Hodgkin lymphoma. We all are familiar with the standard regimens, ABVD and BICOP, which are used across the globe. They have advantages and disadvantages. No doubt ABVD is the most commonly used regimen, but BICOP escalated is also quite frequently used in some regions. Much more acute toxicity with BICOP, but also higher efficacy and a valid treatment option, particularly in the younger and fit patients who can tolerate a more intensive chemotherapy. But there are no doubts that there are unmet needs in patients treated with ABVD. The cure rates are not satisfactory, particularly not in high-risk patients, and also long-term toxicity, particularly bleomycin-induced lung toxicity, is a big problem. Whereas in BRCOP-escalated treatment, one of the major problems is a very high rate of infertility, but also the most feared complication of such intensive chemotherapy, which is secondary acute leukemias and myelodysplastic syndromes. So in order to meet some of these problems, there were a number of studies designed 10 to 15 years ago, which took into use the relatively novel finding, which was that an early interim PET was very good at identifying patients who were very likely to succeed and those who were rather likely to fail first-line ABVD-based treatment. So a new, very good prognostic tool. And that was the background for the design of a number of studies, including this important study, the RAFL study, which came out of the UK but involved centers from many countries, particularly in Europe. So these patients were randomized, they were not randomized, they were all treated with ABVD up front and then followed by a PET scan after 2 cycles. So a randomization took place for those patients, hopefully the majority of patients who were PET negative after 2 cycles. So they were randomized to either continued ABVD or continued treatment without bleomycin, so testing the non-inferiority of a less bleomycin containing treatment for the good responders. And they were approximately 75% of all patients. And here is the result of that randomization. You can see that there was no loss of disease control, so progression-free survival was identical between these 2 arms. Very important study, and led to a drastic reduction in the use of bleomycin in advanced stage Hodgkin lymphoma patients. So this result came out in 2016, already 6 years old at this point. Another important study was the German HD18 study, randomization upfront between a standard arm, which was 6 to 8 cycles of BRCOP escalated, and an experimental arm where all patients, like in the standard arm, began with BRCOP escalated, followed by a PET scan after 2 cycles. And in the experimental arm, those patients who were PET negative after 2 cycles would be randomized. Sorry, they were randomized up front, but those who were in the experimental arm, if they were PET negative, they would continue with only an additional 2 cycles of BRCOP escalated, meaning they would get a total of 4 cycles as opposed to 6 to 8 cycles in the standard arm. And here again, in a non-inferiority design, there was this was a positive study in the way that there was no difference to be found between the standard and experimental approaches for those patients who were PET negative after 2 cycles. In fact, if you look very carefully at the curves, the patients in the experimental arm, here drawn by the dark curve, actually did a little bit better because of less fatal toxicity in the experimental arm. There were a number of infections among patients treated in the standard arm with a fatal outcome, and all these infections occurred after 5, 6, 7, or 8 cycles of BRCOP. Another randomized study was the French AHL 2011 study. In this case, also a randomization up front, BRCOP-based treatment. There was a standard arm where patients were treated with 6 cycles of BRCOP escalated, and an experimental arm where patients who were who were PET scanned after 2 cycles, and those in the experimental arm would continue instead of BRCOP with ABVD. So if they were PET negative in the experimental arm, they would go from BRCOP to ABVD after 2 cycles. And here is the comparison between the treatment arms. Again, those patients who were PET negative, we're looking at those now. There was no difference in progression-free survival between those in the standard arm who continued with BRCOP and those in the experimental arm who went on with ABVD. And this is an important study because we know from other German studies that 2 cycles of BRCOP escalated has very little effect on fertility, whereas more than 2 cycles, so 4, 6, or 8 cycles, has a tremendous effect on fertility. This is important, of course, particularly for the younger patients. Other important studies were the HD15 from Germany and the GITLO 607, and I'll cut the story short. they both showed that a PET scan at the end of treatment could quite safely determine which patients could be treated well without the use of consolidation radiotherapy. This is not talked about so much anymore. We only give consolidation radiotherapy to those patients with an end of treatment PET positive MÁS, and this is due to these randomized studies. But just 10 years ago, we gave consolidation radiotherapy to perhaps 50, 60, or even more percent of those patients with advanced stage Hodgkin lymphoma. So that was the role of interim PET. This has been incorporated into the treatment of advanced stage Hodgkin lymphoma as well as early stage Hodgkin lymphoma successfully in the last 5, 10, 15 years. So the next big step in the advancement of Hodgkin lymphoma treatment, and particularly advanced stage Hodgkin lymphoma, was the introduction of novel agents, and the first one to be successfully incorporated, first in relapsed and refractory disease, and later on now in second line and first line treatment, is brentuximab vedotin. We had seen very high efficacy of that drug, which is an antibody drug conjugate targeting CD30 and carrying the payload MMAE. We've seen high efficacy with high response rates and even high complete response rate in relapsed refractory disease. We've seen the incorporation of that drug in consolidation second line treatment, so improving the outcomes for patients going through high dose chemotherapy and autologous transplant. And Echelon 1 was a randomized study testing the value of brentuximab vedotin in first-line treatment. So this was a randomized study, including more than 1,300 patients carried out worldwide in many, many countries and centers, with 2 arms, standard arm 6 cycles of ABVD, and an experimental arm where bleomycin was taken out and replaced by brentuximab vedotin. So really an upfront comparison between brentuximab vedotin and bleomycin. Primary endpoint was modified progression-free survival, not normal progression-free survival, but an endpoint including progression, death from any cause, but also a situation where end of treatment PET was unsatisfactory, defined as a Deauville score of 3, 4, or 5, and where the patient subsequently had any non-protocol defined anti-cancer therapy that could be chemotherapy or radiotherapy. So the primary analysis was modified progression-free survival at 2 years of median follow-up, shown here, presented by Joe Connors now several years ago, 4 years ago, first at the ASH conference and later in the publication in the New England Journal of Medicine. And what you see here is a significant improvement in favor of the experimental arm by approximately 5%. And it should be noted here that actually the standard arm fared pretty well. 77% modified progression-free survival rate at 2 years for the standard arm is better than any of us had really expected from ABVD from previous studies, but still an improvement in favor of the experimental arm, regardless of whether the analysis was carried out by the independent review facility or by the investigators themselves. But efficacy was not the only difference between the 2 treatment arms. You can see here that there were important differences in the toxicity profile as well. As you would expect, there was more peripheral neuropathy in the experimental arm because brentuximab vedotin, unlike bleomycin, is quite neurotoxic. We know that from single agent use and also in the combination with AVD chemotherapy. You can see that more patients had neuropathy, and importantly, more patients had grade 2 or worse neuropathy brought about by the experimental arm. On the right side, you see another important difference, which is the occurrence of lung problems. So patients experiencing interstitial lung disease, much more common in the standard arm because of the content of bleomycin, as you would expect, and also, just like with neuropathy, the most important difference is the occurrence of patients with grade 3 or worse pulmonary problems. These are really the ones that are at risk of chronic or even fatal lung problems. I'll get back to this. We learned a lot during the course of the Echelon 1 study, and one very important thing is that with brentuximab ABD chemotherapy, we need GCSF. When approximately 70% of the patients had been included, it was noted by the Safety Monitoring Committee that there were too many cases of neutropenia and related problems in the experimental arm. So from that point, mandatory GCSF prophylaxis was introduced. And here you see data only from the experimental arm. And what you see is comparison of neutropenia and all the phenomena that are related with neutropenia before and after the introduction of mandatory G-CSF prophylaxis. You can see that all these problems were reduced, not only neutropenia, but also febrile neutropenia, hospitalizations, infections, and importantly also dose delays and dose reductions. And we all know how important it is to give the right amount of chemotherapy on time if we want to cure Hodgkin lymphoma. Now, these are really important figures, because what you see here are on-treatment deaths. So deaths not from Hodgkin lymphoma, but from the consequences of treatment in patients under treatment or recently completing treatment. On the left, you can see that the deaths during treatment in the experimental arm totaled up to 9 patients, and 7 out of those 9 patients who died from treatment-related complications in the experimental arm died from neutropenia or associated complications. And it's very important to note that all these 7 events occurred prior to the introduction of mandatory G-CSF prophylaxis. On the other hand, in the standard arm, there were 13 on-treatment deaths, 11 of which were caused by pulmonary toxicity. So you can only imagine how these figures would have looked if mandatory G-CSF prophylaxis had been put in place from the beginning, which is how we give A plus ABVD now. And also, and this is important, if treatment with ABVD was carried out not with 6 cycles of ABVD to everybody in the standard arm, but according to RAFL, where only a minority of patients had more than 2 cycles of bleomycin, which we know only rarely gives cause to serious lung problems. Now we move to the recent 6-year update from the ECHELON-1 study. These patients have been followed closely since the first publication of the primary analysis, and we've had annual updates of progression-free survival and important safety measures. We've seen a continued improvement of progression-free survival in favor of the experimental arm. Now we have been looking since the 2-year analysis, not at modified progression-free survival, which was the primary endpoint, but at normal progression-free survival as assessed by the investigators. And this is also what you see here. This is the analysis at a median follow-up of 6 years. And you can see that progression-free survival still is better in the experimental arm. So the difference is maintained and even widened a little bit. So you can see now a more than 7% difference in favor of the experimental arm, which means a reduction by approximately 1/3 in the risk of progression or death from any cause for patients treated in the experimental arm when compared to the standard arm. But the new thing in the 6-year update was not the progression-free survival analysis. This was the first time that enough events had been counted to allow for an analysis of overall survival. And as a positive surprise to most of us, the analysis found a significant reduction in the risk of death. 41% less patients had died at 6 years in the experimental arm compared to the standard arm. And this is the first time that any randomized study has shown a significant overall survival benefit over ABVD. This may be a surprise to most because there have been studies comparing BIACOP and ABVD, but they have not been powered to show overall survival differences, only progression-free survival differences. So this is actually a first to see this reduction in the risk of death. And remember, unlike the BIACOP studies, where patients have had to be relatively young and fit, ECHELON-1 included patients who were quite elderly and to some extent also frail at the time of diagnosis. This is a subgroup analysis of the overall survival between the standard and the experimental arms. And basically what you see is that the overall survival difference in favor of the experimental arm is generally seen across subgroups. There is a tendency to see a greater benefit in those patients with high risk, no surprise. And also if you look at these charts, it looks as though the benefit is higher in younger patients. It must be said, though, that a main reason for this is that the a priori risk of death in elderly patients is of course higher. So the relative reduction of in the risk of death by the intervention or by the experimental arm is less. Actually, the absolute difference in overall survival is more or less the same in elderly as in younger patients. So you can say the number needed to treat in order to avoid one death due to Hodgkin lymphoma or other causes is more or less the same, but the relative difference is higher in younger patients, and this is what you see displayed in these subgroup analyses. We should be quite careful looking at subgroup analyses because already, fortunately, because relatively few patients die from Hodgkin lymphoma in this study, the numbers are quite low. And when you start doing subgroup analyses, of course, you slice up the cake into smaller pieces, which can be a little bit less reliable than the overall analysis. So now we've established that fewer patients died in the experimental arm. So the next question is to sort of look at what the causes for this might be. It's very important to look at the use of subsequent therapies. Now, this study was carried out across the globe in many different treatment situations. So not all patients were treated in rich countries with every drug available at their hands. So it's important to take a critical look at the subsequent therapies, because as we all know, subsequent therapies, they influence not progression-free survival, but they certainly influence on overall survival. If you look at the use of brentuximab vedotin in subsequent therapies, it's no surprise to see that this was more commonly used in patients failing the standard arm than patients failing the experimental arm, because of course brentuximab vedotin was part of the experimental arm. But if you look a little bit further down in this table, you can see the use of checkpoint inhibitors, mainly nivolumab and pembrolizumab. Now, these were more or less equally used in between the two, the failures in the two arms. But I think what springs into the eyes is the relatively infrequent use. And this is one of the main concerns when you look at the overall survival analysis from this study, is that perhaps we should take bit of it with a pinch of salt, because the use of checkpoint inhibition has been less widespread than you would expect in the current treatment situations, where many countries have approved these drugs for later line treatment. Now, what about the causes of death? These are also important. And this is also very, very interesting to see. You can see that part of the difference in favor of the experimental arm is due to deaths from Hodgkin lymphoma or complications. And it's not sure to which extent this difference is mainly due to deaths actually from Hodgkin lymphoma or from the complications of treatment, because this is not always easy to tell. First of all, if you have a patient with progressive lymphoma who dies during treatment, is it because of the disease or is it because of complications? But there is a difference, and the difference is between 32 and 45, and probably we should count at least 2 of the patients with unknown causes into the deaths from Hodgkin lymphoma or complications in the standard arm, because we know that 2 of these patients who died from unknown causes had active Hodgkin lymphoma at the time of death. But still, on the other hand, as I showed you a few slides earlier, we had 11 deaths in the standard arm from lung complications, and we also had 7 deaths in the experimental arm from febrile neutropenia or associated complications. And of course, they are counted into these numbers. So we know that part of the difference that we have observed in the risk of death due to Hodgkin or complications is caused by complications that we nowadays will know how to at least reduce to some extent. Now, deaths from other causes are quite evenly distributed and numbers are very few, but it's very important to note the very marked difference in deaths due to second malignancies. 11 deaths due to second malignancies, most of which were non-Hodgkin lymphomas or other hematological malignancies, versus only 1 death due to second malignancies in the experimental arm. And I will say that, at least to my knowledge, this very large difference is not really well explained at this point. This is another look at the second malignancies, not necessarily the fatal ones, but all that occurred. And you can see that the difference in not the deaths from second malignancies, but the occurrence generally is caused by a difference in hematological malignancies, whereas the number of solid tumors as second malignancies is evenly distributed between the two treatment arms. So just like the previous annual updates from the ECHELON-1 study, the 6-year update that I'm showing you also had important safety updates. And when you look at the fertility data, it was again very nice to see that no effect on fertility apparently is observed. We know that ABVD has very little impact on male and female fertility. So from that point of view, very nice to see that whether you look at female patients or male partners of female partners of male patients, we actually see both more pregnancies and more live births in the experimental arm than in the standard arm. So apparently no important impact on fertility, neither in the standard and certainly not in the experimental arm either. Another thing that has been very nice to see with the annual updates of the ECHELON-1 study has been the development of peripheral neuropathy. I've already showed you that this is a problem, both in the standard arm and even more so in the experimental arm. But unlike what at least I thought, peripheral neuropathy continues to improve with distance to the end of treatment, not only for a couple of years, as most of us would have thought, but even after 3, 4, 5, and now 6 years of follow-up, we continue to see more patients with complete resolution of peripheral neuropathy. And among those patients who still have neuropathy, there is a continued tendency to improvement. So relatively few patients who had neuropathy at the end of treatment live on with unchanged problem. It's in the order of 13, 14% of patients. The rest have either complete resolution, that is the vast majority, or at least some improvement. So to the end of this talk, I will mention a few studies that have been carried out or are going on, with other new agents than brentuximab vedotin. So this was the first look at checkpoint inhibition in first-line treatment of Hodgkin lymphoma, one little cohort from the CheckMate 205 study, which was the study that introduced nivolumab into the treatment of Hodgkin lymphoma. Most of these patients in other cohorts had relapsed or refractory disease, but in this cohort, cohort D, newly diagnosed patients were included, and they had a couple of cycles of, or not a couple, they had 4 cycles of nivolumab prior to conventional chemotherapy, AVD, which was given together with nivolumab. And the point of this study was to show that nivolumab single agent had efficacy even in newly diagnosed patients, first as a single agent, and these are the result, the complete and overall response rate that you see to the left, 67 and 84%. This was after the first 4 cycles of nivolumab, and you can see that all patients responded, and this combination was relatively safe, just like the combination of brentuximab and AVD. And this is another, to me, quite interesting design where checkpoint inhibition is used in a different way, perhaps a more intelligent way. Pembrolizumab in this study was given for 3 cycles prior to the introduction of AVD chemotherapy, but without checkpoint inhibition, so only used as a kind of pre-treatment. And beware, because the numbers of patients really quite low, but it looks quite impressive with 100% progression-free survival and overall survival at a reasonable median follow-up of almost 3 years. Of course, very few centers, probably selected patients, single arm, but still quite attractive. And again, this study, like the CheckMate 205 cohort D study, showed no important safety signals. So it's only logical to expect a randomized study, and such a randomized study is going on. I believe this study will relatively soon complete accrual. The SWOG 1826 study, which compares upfront brentuximab vedotin plus AVD, so essentially the experimental arm of ECHELON-1, with nivolumab plus AVD also given for 6 cycles. So, of course, the results or the primary analysis of this study, which is still a few years out in the future, is eagerly awaited by many of us. So that brings me to the conclusions, which is that, and I'll repeat this again, first-line treatment of Hodgkin lymphoma, whether it be early or advanced stage, it's a balance between efficacy and toxicity, and the most important step forward to meet this balance has still been the introduction of interim PET and early interim PET response adapted treatment. I think it's very important that we keep using this tool even in the era of brentuximab vedotin containing treatment, even though regrettably ECHELON-1 was not designed as a PET response adapted study. So ECHELON-1 has shown a meaningful and significant improvement of progression-free survival in this experimental arm, including brentuximab vedotin over standard ABVD. The 6-year analysis confirms this progression-free survival benefit, and also, as a new thing, demonstrates a significant overall survival benefit, accounting to a 41% reduction in the risk of death at a median of 6 years. We have learned that brentuximab vedotin plus AVD needs to be given with mandatory G-CSF prophylaxis in order to be safe and improve outcomes. There are significant long-term toxicity issues that need to be addressed. We know that peripheral neuropathy is a problem that we need to be aware of. Fortunately, our recent analyses show that peripheral neuropathy is a problem that continues to improve and resolve with time, even as late as after 5 and 6 years after treatment. We've seen some second malignancies, both in the standard arm and the experimental arm. They seem to be less common than after treatment with ABVD, at least in this analysis. This is not well explained, but it's certainly important, and it has a very large impact on the overall survival analysis that I just showed you. Fortunately, we have not seen any impact on fertility, so no reduced fertility after treatment with brentuximab plus AVD as compared to ABVD, quite the opposite. In the end of this talk, I showed you a few studies which have investigated, and an important randomized study which is investigating the potential role of checkpoint inhibition together with conventional chemotherapy. And we, like I said, eagerly await the results of the SWOG S1826 study, which will come out in a few years' time. So with this, I thank you very much for your attention, and I will be happy to take your questions and do a discussion in the live session later on.
Bueno, tenemos tiempo para preguntas, así que si quieren hacer preguntas. Sí, directamente en el micrófono, por favor.
Vamos a abrir el espacio de preguntas, van a ser todas en castellano, hay algún problema técnico y el doctor Hutchings no se pudo conectar, así que bueno, avanzamos con el espacio de preguntas y respuestas. Sí. No sabemos, pero bueno, creo que este es un estudio que abre muchísimos interrogantes y es un lindo espacio, ya que tenemos incluido prácticamente a todo el país en la asistencia de la concurrencia de la sala, que podamos debatir entre nosotros y evacuar nuestras dudas y sacarle provecho a este espacio.
Bueno, yo tenía una pregunta a él porque creo saber la respuesta de Astrid, porque se lo pregunté hace poco, pero lo hago así, escucho la de Caro y los de acá.
Ahora te conteste lo mismo. A ver.
Después, en realidad quería saber si en el día a día usan el PET interino en pacientes bajo brentuximab y AVD y qué hacen con esa información si lo piden.
Es una pregunta que le íbamos a hacer al doctor. Creo que es sumamente importante esta pregunta que haces porque el acceso al PET en nuestro medio es muy variable. Existen medios en los cuales el PET-2 se puede hacer en tiempo y forma, otros espacios que no. Lo importante del estudio de ELECCIÓN es que en el momento que se presentaron los primeros resultados hubo beneficio en la supervivencia libre de progresión en los PET negativos, pero no al fin del tratamiento. Y durante el protocolo tampoco se tomaron decisiones con los resultados que aportó ese PET. Entonces, a priori, si uno decide hacer Brentuxi ABD, puede omitir esos PET si no hay acceso. Cuando nosotros lo charlamos en un ámbito un poco más cercano con él, si está la posibilidad, es una información valiosa porque uno puede tener progresión y puede querer tomar otra conducta con el paciente. Pero estrictamente si la respuesta del paciente clínica está y no tengo acceso al PET, uno podría no hacerlo.
Hola, buenos días. Quería preguntarles con respecto a la polineuropatía, porque me ha tocado ver, y bueno, a Astrid supongo que mucho más, pacientes que tienen un síndrome paraneoplásico asociado al Hodgkin de manifestaciones neurológicas. Entonces, quisiera saber con respecto a la toxicidad, si hay algún score o algo que se ha escrito acerca del riesgo y qué pasa con esos pacientes. Si tenemos pacientes con más riesgo de desarrollar la toxicidad de polineuropatía, que es bastante invalidante.
Sí, no conozco un score de riesgo. En pacientes, son pocos, generalmente estos son pacientes previamente sanos y jóvenes, con lo cual uno no está habituado a ya recibir a un paciente con polineuropatía, pero claramente las recomendaciones en este subgrupo de pacientes muy específicos, tal vez uno no empezaría con un esquema que sí tiene un 10% de polineuropatía grado 3, ¿no? Me parece que eso es parte de las guidelines del NCCN, donde dicen, recomiendan esto como un tratamiento de primera línea, pero hacen una pequeña salvedad de no o por lo menos contemplarlo, ¿no?
Gracias.
Lo otro al respecto es que es una crítica también de otros grupos detractores del Brentuxi ABD, que combinamos dos drogas neurotóxicas. Entonces eso es un poco lo que apoya, sobre todo en el adulto mayor, donde las toxicidades de no solo neuropatías por patología preexistente, sino neutropenias, la toxicidad fue mayor, los tratamientos secuenciales. Por otro lado, cuando la neuropatía es secundaria a la neoplasia, en general es por un mecanismo inmune y mejora con el tratamiento de la patología. Pero opino como Astrid que uno debería, si ya hay una neuropatía clínicamente objetivable, buscar el esquema menos neurotóxico. Quizás en un futuro, cuando tengamos los inhibidores de checkpoint, podría ser una opción para los pacientes con neuropatía.
Y no hay nadie que quiera hacer otra pregunta. También les pregunto si ustedes que tienen experiencia en el uso de estos esquemas han podido hacerlo con la profilaxis con factores, el ciclado en tiempo y forma, o han tenido que diferir los ciclos por no recuperación de la neutropenia.
Bueno, yo tengo experiencia limitada, la verdad, por incluir a los pacientes en el protocolo del GATRA, así que, pero sí, la mayoría de los pacientes puede hacer el ciclado en tiempo y forma, y eso es algo fundamental en el tratamiento de Hodgkin. Está bien claro que uno tiene que hacer todos los esfuerzos, incluso iniciar los ciclos con una leve neutropenia. ¿Sí?
Dani, espera un momentito porque el doctor se pudo conectar, así le haces la pregunta a él.
Igual confío en ustedes, ¿eh?
Participamos igual. Sí. ¿Está? ¿Está conectado?
Bueno, si no hace la pregunta y después si se conecta.
No, quería preguntarle si hay algún beneficio o no del uso de brentuximab en ancianos con alguna combinación, o si es más tóxico o es beneficioso usarlo en este grupo.
Eso nos lleva a una pregunta tal vez un poco más amplia, que es la interpretación o la incorporación de los análisis de subgrupos en este estudio, ¿sí? Porque primero están los resultados de todo el trabajo y después hay un análisis de subgrupo donde se incluyen pacientes menores. El subgrupo analiza mayores de 45 años y mayores de 60 años. Esos subgrupos son cada vez más chiquitos y tenemos pocos pacientes en cada subgrupo. Lo que nos dice ese análisis es que parecería haber menos beneficio en esos pacientes mayores de 60 años con un subgrupo muy chico. Estrictamente hablando, uno no debe digamos, considerar estos análisis de subgrupo, pero la realidad es que están publicados y que los leemos y los miramos, entonces tal vez cuesta verlo, pero tal vez el paciente, como dijo recién el doctor Hutchings, que si interpretamos los análisis de subgrupo, los pacientes que podrían tener un mayor beneficio son los pacientes jóvenes con mayores factores de riesgo de mal pronóstico. Sí, no sé si está conectado.
Igual estuvo muy subrepresentado en el protocolo el grupo de 62 años y la verdad que el no beneficio también tuvo que ver con toxicidades. Ahí volvíamos al eventual uso de los protocolos secuenciales en esa población mayor, que es realmente, creo, un grupo que tiene una necesidad no cubierta. La mayoría queda excluido y es un grupo que tiene un segundo pico y nos encontramos con mucha dificultad para tratar. De hecho, en el estudio que nosotros pudimos publicar, multicéntrico, retrospectivo, la principal causa de muerte fue el no control de la enfermedad en ese grupo y la toxicidad. O sea que es un grupo que creo tiene, sí.
Yo quería apuntar en el grupo Brentuxia-ABVD, bueno, comparado con ABVD, la toxicidad en la médula ósea en caso de que el paciente necesite después, por progresión, ir a trasplante, incluso usando filgrastim, cuál es la toxicidad o qué posibilidades hay de hacer una buena recolección de médula en caso de que vaya a trasplante.
No, a ver, se está bien descritos y detallados el uso de los protocolos de tratamiento en pacientes que recaen y no se evidenció ninguna complicación con respecto a llegar a ir a trasplantes si querían. Son un número bajo de pacientes, ya que las dos ramas fueron con muy buenos resultados.
Yo un comentario y creo que estaría muy interesante que alguno se animara a dar su opinión también. Hi, Martin. Bueno, lamentablemente no creo que nos escuche todavía.
Está silenciado.
I hear you very. Are you talking to Martin Hutchings?
Hello,
Yeah.
Martin. Now we can hear you and we can also see you.
I hear you.
Okay.
I hear you very weakly, and I see nothing.
Well, the room is full of people, Martin. Okay.
Fantastic.
And we are overflooded with questions, trying to respond as good as possible. We've been talking about the role of
The role of what?
yeah. Okay.
Your connection is not very good. Maybe
No.
you should write your questions.
Te hablo
possible?
en castellano porque nos informan que vas a recibir la traducción en inglés. Lo que estaba comentándote es que hablamos sobre el rol del PET en la toma de decisiones en pacientes que son tratados con Brentuxi-ABD, sobre todo porque en nuestro medio la posibilidad de tener PET-2 es difícil y el beneficio, digamos, en la supervivencia global no fue impactado por el resultado del PET, como se había visto en los resultados preliminares. Entonces, un poco, una de las preguntas, y nos gustaría conocer tu opinión, es ¿cuál es el rol de la evaluación de PET-TC a lo largo del tratamiento de pacientes tratados en primera línea con Echelon 1?
I only heard the second half of the question, but I think I have heard a similar question before, so I think I know what it's about. And I have myself in a bad echo. So I think the question is whether there is a role. Could you turn off your microphone, please? Thanks. So I think the question is whether there is a role of interim PET in the setting of BV-contained first-line therapy. Is that correct?
Yep.
Okay. So the Echelon-1 study does not answer this question because essentially the Echelon-1 study was not a PET response adapted study. Of course, there was PET-2 performed in all patients, and we can see that there is prognostic value of PET-2 in both the standard arm and the experimental arm. The difference in prognosis between being PET positive and PET negative is larger in the standard arm, as you would expect, since the experimental arm is more effective. So you can say that it is not as bad to be early PET positive if you are treated in the experimental arm as in the standard arm. But still, you are not much over 60% in 2, 3, 4 year progression-free survival, which in my eyes is not good enough. So the question is, what should we do for these patients? And that is the interesting thing. That cannot be answered by Echelon 1. But in my mind, I do not look at Echelon 1 at the PET results and say, this shows that you shouldn't use interim PET. I think quite the opposite. But the problem is we still need to look out for what to do with the early interim PET positive patients. And probably we also need to refine PET by using supplementary prognostic tools, such as measurement of TARC or even circulating tumor-free DNA. That will be in the near future, so hopefully we'll get better at that. And the next question is what to do with an early interim PET negative patients. Of course, we can celebrate that the treatment works well, but is there a role for de-escalation, just like we have been doing since we saw the results of RAFL with bleomycin? Could we do that as well in the context of BV-containing therapy? That also is not answered by Echelon 1, but these are important questions.
Micrófono. En español.
En castellano. En español, sí, en español.
¿Español? Hola, muy buenos días, doctor Hutchings. Muchas gracias por la presentación a todos. Quería consultarle desde el punto de vista práctico. Sabemos de los buenos resultados del Echelon 1 en pacientes con estadios avanzados, pero aquel paciente que recae o progresa tempranamente a esta estrategia de tratamiento, ¿cuál considera que es la mejor forma de rescate y posterior trasplante? Si es con una línea de rescate convencional o si considera algún lugar para los inhibidores de checkpoint en ese escenario, considerando especialmente que en Argentina tenemos disponibles inhibidores de checkpoint pembrolizumab para este grupo de pacientes.
Yes, so this is a really good question, and this is a field which I believe is really moving in right now and in the years to come. Because of course, the standard of care in patients failing first-line treatment is non-cross-resistant multi-agent chemotherapy, followed by high-dose chemotherapy and autologous stem cell support in those patients who can tolerate such a treatment. That is still the standard of care. I think if you ask me in 3-4 years' time, I think and I hope that this is no longer true for everybody, at least. So I think it depends very much on the timing of the failure. So I believe, I didn't hear the question perfectly, but I think you were asking about patients who are primary refractory or early relapses. In those patients, we will probably still have to go for chemotherapy, but a switch to a different mechanism of action, particularly in patients with widespread disease at the time of failure or relapse, where you cannot incorporate radiotherapy. I think it's important to factor in novel agents very quickly. Novel agents could be single-agent brentuximab, which in my experience sometimes works even if brentuximab fails as part of a combination. But of course, when particularly with the results of Keynote 204, which is an upfront comparison of brentuximab vedotin and pembrolizumab, it's very relevant and tempting to go directly to checkpoint inhibition. And also, and I think this is quite important, there are relatively recent results showing that you can get quite good results out of giving high-dose chemotherapy with autologous stem cell support, even in primary refractory patients who have been brought in remission with checkpoint inhibition. And this is a little bit counterintuitive because often we say that The point of second-line chemotherapy is to control the disease and show chemoresponsiveness. But there are studies from the US showing that you can get quite good results out of bringing patients in remission with checkpoint inhibition and then giving them high-dose chemotherapy and autologous stem cell support. Whether they could do just as well just by getting checkpoint inhibition for a certain period of time, we don't know.
Muchas gracias.
Tenemos otra pregunta.
Hola, Miguel Pavlovsky de FUNDALEU. Buenos días, buenas tardes allá. La pregunta es, en cuanto al acceso del brentuximab, en nuestra región va a ser imposible pensar en un esquema con brentuximab en primera línea para todos los pacientes. Entonces, la pregunta apunta a qué subgrupo de pacientes tendríamos que pensar en indicarlo en base a los resultados del estudio, por ejemplo, en pacientes jóvenes con enfermedad de mal pronóstico, con enfermedad extranodal, o en el otro extremo también pacientes añosos que queremos evitar la bleomicina porque tienen antecedentes de POC o tienen un funcional respiratorio inadecuado para recibir bleomicina.
Yeah, so this is a really good question and a practical question. So I'll start by telling you that in my country, Denmark, we don't have access to brentuximab in first line either. So I can answer you basically from my own situation, which is that I wish we could give this to, potentially to all patients. Because I don't believe the subgroup analyses which were presented in the presentation really support strongly adding BV-AVD to some patients rather than others. But in the real world, this is what we all have to do sometimes. So I would, in my practice, we still like to give BIRCOP or BIRCOP DAC to some patients, and that would of course primarily be the young patients with high risk. Then you have the young patients with low risk, which generally do quite well. So I would probably make the most benefit out of this combination in high-risk patients, and this would be patients with stage 4. It could be patients with extranodal disease, very high IPS. I don't think the results really support one selection over another. Mm-hmm. Old versus young, I think the benefit, if you look at the subgroup analyses, seem to be a little bit more clear among the younger patients, but not so much. Mm-hmm. And the benefit from avoiding bleomycin is, of course, greater in the elderly and comorbid patients. So I would probably pick first those patients of relatively high age with high risk with the high risk score being based at either on stage or on the international prognostic score. But this is from a practical point of view. This is from a point of view looking at which patients can be effectively treated in second line and salvaged. This is from a point of view looking at which patient can tolerate more intensive chemotherapy even in first line. I don't think it's supported by the results section on one, and this is important.
Parece que, bueno, hemos podido hacer un poco de todo, así que damos gracias a todos. Muchísimas gracias, Martín, por conectarte. Pudiste responder las preguntas importantes y gracias a Takeda por este espacio. Muchas gracias.